Welcome to JPHMP Direct, the companion site of the Journal of Public Health Management and Practice. I'm Cheryl Monks, and today I'm talking with two of the authors of an article published in a special supplement highlighting HRSA's investments in public health. The issue underscores the shortage of preventive medicine physicians in the U.S., and the article we're discussing examines preventive medicine in rural America and why more training programs must be located in these rural areas. Joining the program today is Dr. Jennifer Lultschik, Program Director for the WVU Public Health and General Preventive Medicine Residency, and Dr. Christopher Martin, Director of the Occupational Medicine Residency Program at West Virginia University School of Public Health. Media in recent years have referred to the shortage of physicians in certain parts of the U.S. as healthcare deserts. Before we discuss your article, can you briefly describe this shortage of physicians in general and PM physicians in particular?
Well, the term healthcare deserts is a very descriptive term. It suggests isolation and distance, and in fact, it's defined by as a population that is more than an hour's drive or more than 5 miles distance from an acute care medical hospital. And it implies a lack of access to emergency services and medical specialists. And as we see a growth in these healthcare deserts, we are seeing a drop in the absolute number of physicians across the country. The American Association of Medical Colleges has predicted that we'll have a shortage of about 139,000 physicians by 2032. And the reason for this is both an increasing population and increasing healthcare needs in an aging population, and a cohort of physicians who are aging toward retirement. More than 40% of current practicing physicians will be 65 or over in the next decade. And 70% of currently practicing PrevMed physicians are already 55 or older. So we have this drop in the absolute number of physicians. And then we've also seen a disproportionate drop in the number of preventive medicine physicians. Between 2005 and 2020, there was a 16% drop proportionately in PrevMed physicians in the country, so that now we are only seeing 0.6% of practicing physicians are PrevMed physicians. In addition to the problem of disproportion, we have a problem of maldistribution of PrevMed physicians. Only 1.5% of the few PrevMed physicians that we have are currently practicing in rural or non-metro counties. And when you consider that about 1 in 5 or 57 million Americans live in designated rural or non-metro areas, that is a big problem. The number of states with severe or critical shortages is predicted to rise from 4 in 2017 to 23 in 2030. And the states with the larger rural areas are predicted to be the hardest hit. We've seen already an increasing disparity between public health services, for example, between urban and rural areas, so that over the last 5 or 6 years, the services and scope available in urban centers has increased, has expanded, and in rural areas, it has declined. So we've got the absolute number of physicians dropping. We have disproportionate number of them being PrevMed physicians. And then we have this urban-rural maldistribution of PrevMed physicians.
And why is there such a marked maldistribution of doctors across the country? Where are these so-called healthcare deserts, and why do they exist?
In terms of the healthcare deserts, this is concentrated in rural areas, but it's important to note also that urban areas also contain these deserts. The definition is different in an urban setting in the sense that it's considered a 5-mile or greater distance to acute care. But some of our large urban centers, particularly in communities of color, have significant healthcare deserts within them. Nevertheless, this is mostly recognized as a rural problem. In terms of why do we have a physician maldistribution, this truly is the $6 million question, in the sense that This is a problem that has been vexing us ever since the origins of the modern healthcare system, not only in the United States, but every other similar economy. So this is not a problem that's confined to the United States. It's not a recent problem. Every healthcare system has struggled with physician maldistribution ever since the origins of modern healthcare. When we think about, therefore, why do we have this maldistribution problem, we have to think about it in the context of the overall society in which we live. And since the middle of the last century, we have seen progressive urbanization of the public as a whole, as society as a whole. In fact, now 83% of Americans are living in urban areas, and that number continues to go up. So we have to understand this in the context of the cities are where everything is happening. The cities are the areas of growth. It's where the resources are. It's where the universities are. It's where graduate medical education takes place. And so the challenge that we have is, more often than not, a person is going to have grown up and been educated in an urban center. And the challenge is, in someone who has known that all their life, to uproot them from what they have known and ask them to go to a rural area. I would identify 3 reasons as to why that's challenging. First of all, it's disruptive, but beyond that, it's seen as unattractive to people. There's a lot of negative stereotypes. I happen to be originally from Canada, and when I moved to West Virginia, people thought, why on earth would you move to a place like West Virginia? Because they didn't understand West Virginia. They didn't understand the beauty and all that this state has to offer and its high quality of life. So there's a lot of negative stereotypes. Remember, we're not just recruiting a physician, we're recruiting that physician's partner. That partner needs a job. That might be more challenging in a rural environment. And so there is this overall lack of attractiveness of the rural setting, which I would argue in many cases is unjustified. A second factor is harder work. Of course, rural areas are disproportionately affected by the diseases that we're trying to mitigate and prevent, chronic diseases, et cetera. Tragically, West Virginia leads the country in most of those metrics, the opioid crisis, et cetera. So we have bigger problems. And as we're here discussing, fewer resources to address those problems. So that makes for a harder work environment without the support that is often present in an urban areas. That can also be a disincentive to physicians in rural areas. And finally, lower reimbursement. And so we don't have the financial resources as well. And you need only consider all of the rural hospitals that are closing throughout the United States because they simply can't make it financially. And that financial situation is an additional problem that we face in rural America.
So what is the impact upon rural communities that fall into these gaps?
Well, rural communities have to deal with issues of economic disparities, geographical isolation, disparities of infrastructure, transportation issues, and differences in educational and employment opportunities, things that we collectively often call some of the social determinants of health. And these drive a lot of the health disparities between urban and rural communities. So what we see is that adults in rural communities have higher mortality rates for all of the leading causes of death, like cardiovascular disease, cancer, chronic lower respiratory disease, unintentional injury, and stroke being the top 5. And they also have higher rates of smoking, higher rates of obesity. Their levels of physical activity tend to be lower than those recommended. And the diseases of despair, as they're called, these substance overdoses, liver disease, and suicidal ideation or behaviors are more common in rural communities. And the difficulty is that access to mental health services and to addiction services is much more difficult in those rural areas. Rural populations are also more likely to be exposed to certain occupational hazards, in particular dust and vapors and gases. And for example, in West Virginia and Appalachia, occupational exposure to coal dust and silica. This is a specific factor or specific hazard that really has created a lot of morbidity and mortality.
Your article looks at one way to address the disparity of preventive medicine physicians in rural areas like Appalachia. Would you tell us about it?
Again, as I indicated earlier, we don't represent to have an easy fix for the physician maldistribution problem that has been so intractable. But there is an interesting predictive variable for where physicians practice. It's reasonably powerfully predictive, and it's been consistent year after year. And that is where the physician completed their final graduate medical education program. And again, as I said earlier, part of the problem that we have is if we rely on people to move from urban to rural areas, that's going to be a challenge. However, it's an old adage in any institution, including universities or healthcare systems, that it's much easier to retain than recruit. And so when you look at the percentage of physicians who remain in the state where they did their last residency, it hovers around 50%. And that's been a consistent number year after year after year for the many years that the Association of American Medical Colleges has been collecting this data. So what we argue in the paper is that we really need to have more preventive medicine residencies based in rural America. While we're very supportive of elective rotations in which residents in urban programs come and gain exposure, we think that that's not a replacement for having the training programs based here. What that means is the individual moves here and commits to practice or at least training in a rural setting. And we believe that once we get them here and they see all of the wonderful opportunities, both professionally and personally, that are available to them, when we dispel some of these negative stereotypes, that in fact, we're going to be able to retain them and at least address in part this shortage that has vexed us for so many years.
There are only 4 preventive medicine residency programs in the entire region of Appalachia. Why aren't there more programs? I know you've already touched on this a little, but can you describe some of the systemic challenges that these programs face?
There's a number of significant systemic challenges. And I should just clarify quickly that we have 2 preventive medicine residency programs at West Virginia University. And out of 64 non-military programs in the country, there's only 4 rural programs in the entire country. So that said, what's the reason for that? Well, there are several, and one major challenge is that preventive medicine programs depend on competitive national grants that renew on a 5-year basis. The vast majority of other programs are funded through CMS and through institutions. The work involved in obtaining and maintaining a grant and reapplying is significant. And so it could be a real barrier to a small center in a rural area that's looking to start a PrevMed program. Secondly, there's an unbalanced allocation of funding. There's a disproportionate share of funding that goes to programs in large urban centers with name recognition. This is known commonly as the Matthew effect, which recognizes that in human and corporate behavior, more is given to those who already have. We see it in scientific funding. A recent study showed that there was a 100-fold discrepancy in NIH research funding to individual states that had nothing to do with their scientific productivity. It is a factor of human nature. In the same way, the staffing and funding of medical residency programs favors urban areas. And as Dr. Martin mentioned, the urban areas are where more people live. It's where the universities are. It's where the large programs are. And so what we found was in 2018, only 0.1% of all residents were training in rural areas. And in preventive medicine, there were a total of only 21 residents across the whole country training in rural programs. Another major systemic obstacle is what we've talked about already, a real shortage of trained preventive medicine physicians in rural areas. And what this means is that we lack trained preceptors to supervise residents during their rural rotations. In West Virginia, we have 55 counties, 48 county health departments, of which 30 have fewer than 5 employees. Only 3 have full-time medical health officers, and only one of those is ABEM certified. So we have a real challenge in finding qualified supervisors for residents. And lastly, in terms of establishing programs and attracting residents and maintaining programs, there have historically been limited numbers of full-time jobs in preventive medicine in rural areas, and that's due to funding and the current structure of things. So there is a discrepancy between the very real needs that we see and the apparent demand. The demand should be much greater, and it needs to change so that we can attract young physicians who will want to train in rural areas and stay there and practice.
How do your programs at WVU take on these challenges?
That's an excellent question. And why are we having success with preventive medicine residency programs? We've had a long-running occupational medicine program since the 1990s that I direct, and we were able to build from that foundation to extend it to another preventive medicine program, the public health general preventive medicine residency that Dr. Lultschik directs. And so one reason was we were able to extend into GPM, having a solid base in occupational medicine to do so. We're very lucky in Morgantown, West Virginia. We have a CDC NIOSH facility located quite literally next door to where I am right now on our campus. And that has really afforded us a much deeper set of expertise and faculty depth to at least partially address some of the challenges that Dr. Lultschik described earlier. So we have great expertise. Most of these individuals, as you can imagine, are occupational medicine physicians, but some of them are public health and GPM board certified as well. And we've been able to tap into them as a great resource. We also feel that we've been the benefit of our own strategy or tactic, so to speak, in the sense that we have used our occupational medicine residency to successfully recruit and certainly within our institution address the shortfall and the challenges of recruiting to rural America. So I'm very proud to say that Dr. Lultschik was my resident. And in fact, the last 4 clinical faculty that we have recruited within our group were all graduates of our residency. Again, I think that's a testament to what is possible. It's certainly been successful for us on the occupational medicine front, and we believe applying that strategy more broadly nationally by encouraging and being sensitive to the obstacles of preventive medicine training programs in rural areas, we can hopefully address that through creating these pipelines of people who want to stay where they are rather than trying to recruit them from another location.
Is there anything else that you would like to add that we haven't already discussed?
Well, I'd just like to say that I think we are at a tremendous moment of opportunity. We've never needed preventive medicine residents more. The COVID-19 pandemic has shown us how fragile and how really understaffed our public health and preventive medicine structure is. And I see a great opportunity here. I think it's time, it's our moment to invest in public health and preventive medicine and to really address head-on the crisis that we have in chronic disease, in addiction, that we see all across the country and especially in rural areas. We need programs that have a specific mission and emphasis to train physicians in rural areas and encourage them to stay and practice there. And we don't want to become a self-fulfilling prophecy. If we fail to support and encourage more rural preventive medicine programs, we can't be surprised when physicians don't take up practice here. Dr. Martin has alluded to the difficulty in recruiting from urban areas to rural areas for all the reasons he mentioned. But if we take up the challenge, we can do better. And that's our opportunity and our mission now.
In addition, I think the COVID pandemic is relevant here beyond what Dr. Lultschik said about the obvious reinforcement of our need for greater numbers of preventive medicine physicians in this country. COVID is going to change every aspect of society in profound and long-standing ways that we don't yet fully understand. But one thing has become clear to my mind is that rural areas have become a lot more attractive for people to live in. Our state has embarked on a very creative effort with funding from a donor to encourage remote workers to settle here. And the strategy is that you can have a quality of life here that is perhaps something you didn't realize to be as important as when you were in a pandemic. We saw the people living in urban areas were much more constrained in terms of complying with CDC recommendations than we here in rural areas. I live a short drive from my office. It takes me about 20 minutes to get home. But I can also access rivers to go kayaking and boating on. I can hike and never run into a single person at all. And I would argue that this pandemic has really had people rethink. We've seen massive increases in outdoor recreation. And so I think rural America may become a much more attractive proposition, in addition to looking at creative and innovative ways through telemedicine, et cetera, where we can overcome some of these physical barriers as well. But we think and hope that people will find places like West Virginia, Appalachia, and rural America more broadly to offer them a higher quality of life and an ability to enjoy a life that is full with all that can be offered only in places that are rural.
To learn more, read Preventive Medicine for Rural America, Why More Training Programs Must Be Here. The article appears in a special issue of the Journal of Public Health Management and Practice, which focuses on HRSA's investment in public health. This feature was brought to you by JPH-MP Direct, the companion site of the Journal of Public Health Management and Practice. If you haven't done so already, please subscribe to our YouTube channel and click the notification icon so you will be notified each time we upload a new video.